Okay, and today we are very excited to welcome the team from Manat Health. This is a session that we do every July and one that we always look forward to. So I'm very excited to have the Manat team here to share insights from the health AI policy landscape through the first 2 quarters of 2026, both at the federal and state level. And I will turn it over to the Manat team to introduce themselves.
Great. I'm going to kick it off and I'm going to, Maya, are you sharing the screen for slides?
Sierra is momentarily.
Great. So I will introduce Manat and I'll introduce myself, and then I think each of the speakers will introduce themselves since we each are going to be presenting. So we're from Manat, Phelps and Phillips, and we all work in Manat Health. We are an integrated legal consulting and policy group, which means that lawyers and consultants and individuals who used to work in the government or healthcare startup founders, technologists, we work side by side to provide integrated advice and support to our clients. And we have been tracking the AI federal and state legislative, regulatory, and policy landscape for the past few years. And so we are excited to present on sort of the trends that we're seeing in 2026, many of which are a continuation of trends that we saw in 2025 and do represent a divergence from trends actually we saw under the former the Biden administration when we did this presentation back in 2024. So we flip to the next slide. I'm sorry, and I'm Randy Siegel. I'm a partner in the healthcare group. I'm a healthcare regulatory and compliance attorney, and I co-lead our health tech work with Jared Augenstein. So in terms of our agenda, we're going to do a brief overview of federal and state legislative activity in 2026. We're going to then talk through some actions from federal agencies that are looking to advance adoption of artificial intelligence in healthcare, and then open it up for questions and discussion. So feel free to put questions into the chat, and we will get to them in the discussion section. So if we turn to the next slide, at a high level, federal and state policymakers continue to generally approach artificial intelligence legislation and regulations from two pretty divergent perspectives. States remain focused on establishing guardrails for the use of artificial intelligence, looking to promote transparency, most commonly through requiring disclaimers to the end user that they are interacting with artificial intelligence, while federal government has taken largely a deregulatory posture, really trying to promote the innovation around artificial intelligence more broadly, and specifically through a number of programs, really trying to lean into how AI can advance access and improve patient experience as well as efficiencies in healthcare. They are also taking several actions to deter states from regulating artificial intelligence, and in particular, broad-based laws that regulate developers of artificial intelligence. We turn to the next slide. If we focus on 3 specific activities by the federal government in 2026. So the first one that we want to double click on is the executive order that came from the Trump administration in early June that represented actually a notable shift in federal AI policy. So as I just mentioned, the administration has generally focused and favored a very deregulatory approach, hoping to promote artificial intelligence development and adoption in the United States, believing that otherwise we may be left behind. But this executive order does demonstrate the administration's willingness to establish some federal oversight mechanisms, potentially in areas where national security and cybersecurity risks might be implicated. The order establishes the first formal federal framework for collaboration between the government and AI developers of frontier models on the issue of security. It directs federal agencies to strengthen cybersecurity across national security systems, civilian federal networks, and critical infrastructure through increased deployment of AI-enabled defensive technologies. And specifically with regard to healthcare, the order calls for expanding access to advanced cybersecurity capabilities to government agencies and critical infrastructure operators, in which they actually highlight rural hospitals as being one of those. Importantly, the executive order goes beyond traditional cybersecurity initiatives by creating a federal process to evaluate highly advanced AI models that may pose national security risk. The participation, though, in some of these voluntary evaluation model, the evaluation models is at this point voluntary. So it's a voluntary framework that they're developing that advanced frontier models may provide pre-release access to the federal government for security evaluations. A bunch of these directives are supposed to occur within 60 days. To date, I don't believe that we've seen a lot of evidence that the agencies have engaged in some of these activities that were directed under the executive order. However, they have several days left under that 60-day timeline. So the key takeaway here is that while the executive order does not impose broad AI compliance obligations on healthcare providers or most deployers, it does signal that federal AI policy may be increasingly distinguishing between ordinary AI applications and frontier models as they relate to national security concerns, and open to at least developing a voluntary sort of oversight framework for these large frontier models. In the center, we highlight that there was some congressional activity in that there was a bipartisan draft of legislation that was circulated in a discussion draft called the Great American AI Act. This proposal also primarily focuses on frontier model developments rather than downstream users. Consistent with emerging international approaches to AI regulations, the draft would require developers of advanced AI models to implement certain plans to address catastrophic risk, safety concerns, and undergo oversights by independent third-party auditors. The framework also contemplates certain transparency obligations and whistleblower protections for those who report concerns around frontier AI model development, and the use of independent verification organizations to evaluate compliance. The most significant aspect of the proposal, I think for purposes of thinking about state AI legislation, is its approach to federal preemption. And so this draft would preempt state laws specifically regulating the development of AI models, so on the AI developers, not the deployers. And the preemption would only be for 3 years. And it would otherwise preserve states' authority to regulate deployment and use of AI systems and other sort of generally applicable state laws. This reflects a growing concern that maybe the patchwork of state laws, in particular to AI developers, could impede development and national competitiveness. However, we note that this draft has not been formally introduced and is not actually proceeded to get much conversation. Lastly, just want to highlight on the right-hand side that the Department of Justice intervened in a litigation in Colorado that was brought against the state for the former version of their AI law that was a broad-based law focused on AI algorithmic discrimination and bias and requiring certain transparency requirements. The lawsuit was initially filed by XAI that was challenging Colorado's former version of its AI consumer protection law, alleging, among other things, that the law violated First Amendment. The Department of Justice intervened to support the challenge, arguing the state's algorithmic discrimination provision violated the Equal Protection Clause under the US Constitution, and also alluding to First Amendment violations. Shortly after the DOJ's intervention, the federal district court stayed enforcement of the law in light of the fact that the Colorado law was actually amended during this period, which Maya is going to talk through. The key takeaway of this case is that the case kind of extends beyond Colorado potentially because it represents the first major action of the Department of Justice AI litigation task force, which was convened in response to an executive order from the Trump administration in late 2025. And it may provide an early indication of how the federal government will challenge state AI laws that they view inconsistent with national AI policy. It also highlights the growing tension or the continuing tension between state AI regulation and federal efforts to establish more uniform national framework. And so with that, I will turn it over to Maya to introduce herself and also talk through sort of how different the state landscape is.
Thank you, Randy. And good afternoon, everyone. My name is Maya Shashua. I'm a manager with Manat Health and, among other things, work a lot on our efforts to track both state and federal activity related to health and AI. So really happy to be here with you all this afternoon. So turning to the states, as Randy said, we really saw a surge of legislative activity in the first half of this year. We tracked over 180 AI bills that impact healthcare stakeholders, which exceeds how much we saw in 2025. However, to date, we have only seen 29 bills signed into law in 20 states. So I'm going to spend a little bit of time touching on some of the most interesting bills and themes that we saw come up. And similar to what Randy said, we really did see that states focused on areas similar to what we saw in 2025, chatbots, healthcare payers and their use of AI, providers' use of AI, and disclosures to end users. So going in a little more detail on what happened in Colorado this past quarter, the state enacted SB 189, which repealed and reenacted the AI consumer protection framework that was established in 2024 by SB 205. SB 205 included numerous anti-discrimination and transparency requirements for AI developers and deployers, and it was originally signed with significant reservations from the governor. It was explicitly named in President Trump's 2025 executive order on national AI policy. And the legislator worked to amend this law multiple times during the 2025 session, but was ultimately not successful and ended up delaying the law's effective date rather than make revisions. In the fall of 2025, the governor convened a work group that ended up proposing a revised bill ahead of the law coming into effect. That ended up becoming SB 189, which passed and was signed in May. There are some key changes that this repeal and reenactment affected. The first one is that the new law has significantly reduced developer and deployer compliance requirements. It has broad exemptions for HIPAA-covered entities and FDA-regulated medical devices. So really the HIPAA-covered providers that maybe would have been affected by this law previously have more minimal requirements at this point. Developers, the reenacted law eliminates developers' duty of reasonable care against algorithmic discrimination, which was a real cornerstone of the previous provisions, removes requirements for deployers of AI tools to implement risk management and impact assessment requirements, and revises consumer notice obligations to allow more general links to website disclosures to fill in the gaps. So what we're watching here really is how this plays out given the Department of Justice's intervention in the XAI suit against Colorado 205. The law has since been amended, so it really remains to be seen what happens with the suit on an ongoing basis in the months to come. Moving away from Colorado, we also saw a really interesting law come into be enacted in Connecticut, SB 5. This bill is really sweeping, has multiple AI-related provisions that touch on some of the most common themes that we see across states. There are significant requirements imposed on companion chatbots, including provisions specific to mental health and safeguards for users under the age of 18. There's whistleblower protections established for employees of Frontier developers who raise concerns about safety. And interestingly, the state is directed through this law to establish a plan to create an AI regulatory sandbox and launch a pilot program to establish up to 5 independent verification organizations, which will be used to assess AI models. Um, Connecticut, I think, was not alone in focusing on chatbots. This is an area we see a ton of attention, both in the media and also from states. There were over 80 bills introduced in this area. We ultimately have seen 8 bills enacted into law to date across 7 states, many of which, similar to Connecticut, contain specific requirements to protect minor users and specific requirements related to mental health provisions, especially as it pertains to mental health crises. One area we saw some interesting action in the chatbot realm is 3 new laws enacted this year that contain provisions that prohibit chatbots from representing themselves as mental health care providers. This is an area that's been in the news a bit lately. There was a recent lawsuit against OpenAI claiming that a chatbot offered dangerous medical advice that led the user to delay professional treatment for what ended up being a serious health condition. The state of Pennsylvania also has established a suit against Character Technologies, which is the creator of Character.ai, using the Pennsylvania Medical Practice Act to argue that the company itself engaged in the unauthorized practice of medicine after one of its chatbots allegedly represented itself as a licensed psychiatrist with a fabricated license number. So an interesting test that we'll be following to see whether the AI developer itself can be the regulated actor. Couple other areas to touch on before we move on. States are continuing to introduce and pass legislation on AI in clinical care. There were 7 bills enacted into law this year so far, many of which focus on the permissible use of AI in therapy and psychotherapy services. There were 3 bills enacted in Maine, Rhode Island, and Colorado that mandate patient consent prior to the use of AI in the delivery of therapeutic services. And we saw an interesting bill in Indiana that prohibited providers from using AI to submit claims without review by a provider or another individual. So starting to see some action relating to claims and payment on the provider side, not just on payer use of AI, which is a trend we've seen since we first started closely tracking state legislation in 2024. Many of these bills prohibit sole use of AI for denials of prior authorization or adverse coverage determinations without the review of a clinician or human reviewer. We saw a few laws this year that required disclosure of the use of AI to the plan enrollees, and 2 states enacted laws that required reporting to the state by the payer. And I think one interesting new thing that we saw in payer use of AI, there were 2 laws enacted to date, one in the first quarter and one this second quarter, that prohibit AI from downcoding claims without oversight from a licensed physician. So, going to continue to watch if those bills have motion in coming months, but especially in 2027 and beyond. I think more broadly, right now, only 7 states are still in session for part or all of the remainder of this year. There's also a few bills pending governor's signature in New York. So most of the bills that we are tracking outside of the states still in session will not be adopted and may be taken up again in the following session. So I will pause there and pass over to Jared to talk a little bit about some specific action we saw.
Great. Thanks, Maya. It's good to be with everyone today. I'm Jared Augenstein. I'm based in our New York office at Manat. I've been with Manat for about 14 years, and I have the privilege of co-leading our health tech and health AI practice with Randy. So one of the things that we wanted to highlight that has had a lot of sort of activity this year is around the regulation of AI as a clinical service provider. And there was a bill that was introduced in Iowa and Idaho that's based on a model bill from the Cicero Institute called the AI Medical Services Act, and wanted to share, a bit about that bill since it's getting a little bit of traction in sort of state policy circles, but more importantly, it's getting there's a fair bit of dialogue in sort of like the AI policy world generally about this concept. And so basically what the Cicero bill does is create a new class of licensed provider called an AI augmented and autonomous service provider. So you can think of this like there are licensing constructs for physicians and for nurses and for APPs and for other types of licensed professionals. This basically creates a new class of licensed professional, except the professional in this case is an AI. It's a piece of software. This would treat the AI as a clinical service, importantly, rather than a regulated medical device, which would go through sort of an FDA process. There are a couple of sort of constructs outlined in the bill. One is risk tiered licensure. So it establishes a tiered licensing structure based on level of autonomy. So assistive with human oversight and fully autonomous, and clinical risk, think low, medium, sort of high risk clinical indications. And it sort of tries to situate that risk tiered licensure to exceed the performance of a reasonably prudent human healthcare provider before receiving full practice authority. There's a sandbox sort of construct within the AI Medical Services Act that allows AI systems to operate under supervised conditions before achieving full licensure, sort of different sandbox concept than we've seen in states like Utah and Texas and elsewhere, and I'll describe that a bit more in a moment as well. And importantly, it would preempt existing sort of state licensure boards from imposing requirements that would conflict with the AI augmented and autonomous service provider sort of practice that's outlined in the framework. So again, this bill, it basically creates, you think of the ways that clinical AI services can be regulated now. You have software as a medical device, which sort of goes through an FDA pathway. You have clinical decision support tools that are used and deployed and overseen by clinicians who ultimately sort of maintain responsibility and liability. And this is proposing to create sort of a third pathway that would oversee and regulate clinical AI programs of various different levels of clinical risk and autonomy. Again, the bill was released as a model bill in late winter this year. I think it was like February. So most state legislatures were already in session. So it's sort of late in the cycle. It was introduced in Iowa and Idaho. It didn't advance in either state beyond being introduced, and both of those states' legislative sessions have concluded, so it won't sort of progress this year. But it's a construct and a bill and a concept that we are tracking, closely as we start to look towards the 2027 state legislative session in most states. So if we go to the next slide, this construct sort of contrasts to where we've seen more activity over the past few years, which is the creation of AI sandboxes and related regulatory mitigation agreements. There are several states that have had sandboxes in place for a range of different sort of industries. They were common in the financial services industry for many years. The Utah sandbox is a sandbox that many of you have likely heard about. Utah, a few years ago, created an Office of AI Policy to oversee a regulatory learning laboratory and administer a regulatory relief program, waiving specific state legal and regulatory requirements, sort of commonly referred to as a sandbox. And Utah has agreements in place with several providers of healthcare, mental health, dental services that provide flexibility from certain state law and regulation. I'll provide an overview of their agreement with Doctronic, which is sort of the most well-known use case of a sandbox being deployed in healthcare to date. Texas also has a sandbox that went live at the beginning of this year, although is sort of in a more nascent stage of development. And to our knowledge yet, doesn't have any sort of agreements in place with health tech providers. There's another sandbox that's there are other sandboxes in other states that also are sort of dormant from a healthcare perspective. We have also seen sort of new activity. So Delaware created a sandbox last year, and the Delaware AI Commission has been working with the Delaware Secretary of State to establish an AI regulatory sandbox framework to test technologies that utilize agentic AI. There's draft legislation sort of related to the Delaware sandbox that's under development, and Connecticut passed SB 5, which is a broad health AI piece of legislation, one component of which was to establish a sandbox that would start about a year from now. And so the Commissioner of Economic and Community Development is starting work on structuring the Connecticut sandbox. Interestingly, in Connecticut, including the assessment of establishing reciprocity agreements with other states that have sandboxes in place. So if we focus in on Utah for a moment, go to the next slide. So Utah's regulatory relief program structured an agreement with Doctronic last year in October that allows Doctronic to authorize 30, 60, or 90-day renewals of medications that have already been prescribed by a human clinician, launched in a 3-phase approach. It limits renewals to about 200 commonly prescribed medications. It excludes controlled substances and addiction medications. The first phase of the pilot, in the first phase, the first 250 prescriptions within a given class will have the AI-generated renewal decision reviewed by a licensed physician prior to submitting the renewal to the pharmacy. For the next 1,000 fills, they'll have the AI-generated renewal decision retrospectively reviewed. And then in phase 3, there's sort of a sampling approach where a subset of the scripts get reviewed for quality sort of oversight perspective. All of the Utah sandbox agreements are 1 year. So this one was put in place in October of 2025. It'll come up for renewal in October of 2026. So if we go to the next slide, there's been some pushback on, there was some pushback earlier this year on the Utah approach. The Utah Medical Licensing Board published a letter of concern claiming that the Doctronic agreement is implemented without prior consultation from the Board of Medicine. The board raised clinical safety concerns, noting that prescription refills require reassessment, clinical decision-making to monitor side effects, drug interactions, and continued medication effectiveness. And the board sought immediate suspension of the program. The Office of AI Policy and the Utah Division of Professional Licensing reviewed the letter and declined to suspend the pilot, noting that in phase 1, physician review is required, as I mentioned, for every AI-generated renewal, and that the board, the Medical Licensing Board, serves as advisory, not approval capacity to the Division of Professional Licensing. So there's some back and forth. We have sort of heard that there is now, more of a working relationship between the Utah Medical Licensing Board and the Office of AI Policy. And so it's in sort of an area that we're watching closely as other states seek to stand up their own sandboxes, sort of the relationship between the governance infrastructure for the sandboxes and medical licensing boards and other healthcare professional licensing boards. Looking ahead, Utah's articulated a few additional areas of interest, including diagnostic decision support, new prescription initiation, mental health support, and specialty care pathways. And so we expect there to be further agreements entered into by the Utah Office of AI Policy as well. So with that, I'm going to hand it back to Maya, who's going to cover some of the federal agency activity that we've seen over the past year. Maya?
Thank you. So we'll go through a couple recent notable actions from federal agencies and then turn over to discussion and Q&A. So we can go to the next slide. The first agency action we wanted to touch on is the Center for Medicare and Medicaid Innovation, CMMI's WISER model. This model uses AI and machine learning vendors to review prior authorization requests for select Medicare fee-for-service services. It has been live across 6 states since the start of the year, but we've been tracking some significant pushback this quarter. In May, congressional Democrats moved to block the WISER model after the Government Accountability Office, GAO, determined that WISER constitutes a rule subject to the Congressional Review Act. There was a Democratic-led measure in the Senate to repeal WISER that failed on party lines just a few days ago on July 16th. So a lot of action coming out of Congress, mostly from Democrats. However, there's also been news and reporting on WISER's implementation in the 6 states in which it is live, and some reporting on issues with the implementation. CMS ended up issuing in June a warning letter and request for a corrective action plan from a WISER program participant called Vertex Health, who is the participant in Washington State. They had garnered significant media attention and were found to be out of compliance with a required 72-hour turnaround time for prior authorization and prepayment decisions for procedures covered by the WISER model. So we expect to see some more action in this area, but we'll be tracking this pushback if anything emerges from other states beyond Washington and beyond Vertex Health. On the next slide, another CMMI program that we're tracking is the Advancing Chronic Care with Effective Scalable Solutions, or ACCESS model. The first cohort of model participants launched this year. It's a 10-year national voluntary demonstration focused on incorporating outcome-aligned payments for achieving defined clinical targets into Medicare Part B for chronic condition management across 4 tracks, which you can see in the table on the screen. The sort of takeaway for AI and digital health here is that the model's relatively low payment rates compared to current market rate for products means that participants in this model will be relying on automation and AI that can be scaled and still succeed under this lower reimbursement rate. The access model is paired with a Food and Drug Administration FDA Tempo pilot for these digital health solutions. So you can go to the next slide and detail some of the updates from there and from FDA overall. Just a few days ago, FDA announced the first participant in the Tempo pilot paired with the access model. The Tempo pilot enables manufacturers of digital health devices that do not yet have FDA authorization to apply for participation and request FDA exercise enforcement discretion to allow Medicare members aligned with the access model who are, participating within that model to use the device, even though it is still pending FDA authorization. This first participant, Dexcom's glucose health program, allows patients, their caregivers, and care teams to monitor metabolic and nutritional status. It delivers tailored guidance and provides real-time data and AI insights. It's focused on diabetes and prediabetes. We're expecting to see some additional announcements from FDA on participants. I believe it's up to 10 in the first cohort, so we will be keeping an eye out for that. Similarly, or within the same agency, FDA, but outside of the Tempo pilot, a digital health company, and if we could just stay on the same slide for a moment, a digital health company, UpDoc, announced that it obtained FDA clearance for its AI product that interacts directly with patients in between their medical appointments and adjusts medication doses within parameters already set by a patient's human clinician. This approval makes Updoc the first digital health company to receive software as a medical device clearance for a product that's using patient-facing large language models. So again, this is outside of the Tempo pilot, but something else that we're watching as FDA, receives requests for clearance from other companies who might be attempting to use the same SAMD pathway. Last slide, just wanted to give a nod to the advocate model, which is launched out of the Advanced Research Projects Agency for Health. It was launched this year and seeks to develop the first FDA-authorized agentic AI technology focused on cardiovascular disease. So this includes development of autonomous clinical AI agents that interact directly with patients. It also includes the development of an AI-based overseer and verification functionalities to curate both the training data sets and support trials. So it's a really multi-layered effort going on out of ARPA-H. We are watching for award team selection. We're anticipating it coming through in the next few months, and we'll be keeping an eye on how this proceeds. With that, Jared, Randy, feel free to add in anything to the models I flagged, and otherwise I think we can turn to Q&A.
Okay, feel free to put questions in the chat or raise your hand and I can call on you to unmute. I'm seeing we already have 2 questions in the chat. The first one is how can the public best pursue legal counsel when they believe AI models have returned incorrect results?
I actually am not sure exactly what the question is asking, so I don't know if Kate, you can clarify in the chat or come off mute.
I was actually trying to direct my question towards just the public lay people when they say, I don't trust or I don't believe that this result is true. Is the advice really, even if it was your family member, would it be go back to your physician, or is there any recourse for the public when they think that they've gotten something wrong? If it was a doctor, you'd say, oh, maybe I've got to go back to another doctor, get a second opinion. But I'm just curious if there's been any consideration for how people are going to start interacting with these systems and then have some kind of, I don't want to say recourse, but what do you do if you think it might be wrong?
So I mean, I can speak from like the regulatory framework or lack thereof and guidance around this topic. I mean, a number of the laws are, require disclaimers or prohibit a chatbot or information provider from providing or representing themselves as a healthcare provider. But absent the the tool, presenting itself in that way or not providing appropriate disclaimers, there's not much of a recourse under the law, although certainly you could bring a consumer protection claim if you felt that the chatbot, even though not saying I'm a doctor, provided information or represented itself in a way that would convey that they were a medical provider, that such that it could mislead the consumer. But otherwise, I don't think the case law is developed here, although we're starting to see some litigation, as Maya mentioned, against chat bots or tools that are believed to have caused harm, whether that's poor clinical advice or, enabling or encouraging someone to commit suicide. But it's really in its nascent state, and litigation often trails technology by a significant bit. So I'm not sure. There's not much guidance there to give from a legal recourse perspective. In terms of AI deployment within a healthcare system, the laws that I referenced around sort of not representing itself as a chatbot or providing certain disclaimers are unlikely to be available in that context.
Next question I'm seeing is, could you share more information on the updoc approval?
I don't think we have any more information than you do, Ting. I hope I'm pronouncing your name correctly. It was clarified later that because there's the press release in July, and then there was the public 510K from December, and then it was confirmed later that it was in reference to the December 510K that the press release was sort of announcing the approval.
We'll continue to keep an eye on that then. Um, I'm going to go to some other questions that we received from registration. In the meantime, feel free to post questions in the chat or raise your hand and I can call on you to unmute. Are there any unique federal or state policy implications that you think would be specific to federally qualified health centers, perhaps around like Section 330 of the Public Health Service Act?
Here, can you repeat that? I'm sorry, it got a little muddled.
We got a question during registration just asking, are there any, do you think, unique federal or state policy implications that will uniquely impact federally qualified health centers or other community health centers perhaps related to Section 330 or Public Health Service Act?
I'm not aware of anything that would uniquely, I work with a number of FQHCs and I'm familiar with the FTCA coverage. I don't think there's anything in particular yet, because while there's been a lot of activity at the state level, there still has been, not a lot of laws passed with regard to impacting FTCA coverage or sort of shifting any sort of paradigm under FTCA coverage from a malpractice perspective. In terms of unique or state policy implications specific to FQHCs or community health centers, there's nothing specifically targeting those use cases. In this presentation, and Jared, I don't mean to put you on the spot, there might be some policy implications under the Rural Health Transformation Program that may help support or drive adoption or support for FQHCs and community health centers in adopting certain technologies. I don't know, Jared, if you want to touch on that.
Yeah, I don't think it's a good flag. I don't think there are any like additional, regulatory requirements or regulatory like burden imposed by RHTP, but there is opportunity. To Randy's point, every state's getting about $200 million a year for the next 5 years for their rural health transformation program. It varies a little bit depending on the state. And many states, there are several examples of states that have created sort of pots of money that are supposed to be invested in AI infrastructure and program development. Some of it it's sort of every state can structure their program and how they allocate the funding in different ways. In Vermont, for example, there's a pot of funding that's going to support buying ambient scribe technology for providers that don't have it already, rural providers, including CHCs. And in other states, there are resources that are available for provider organizations like CHCs to apply to develop new clinical AI and develop and implement new clinical AI programs. So I think it's a good area. I think it's a good, obviously it's balancing out significant sort of federal funding cuts from OBA, but it is one of sort of the bright spots of like new resources available to help organizations invest in technology like AI.
I see Ella has their hand raised. If you wanted to come up.
Hi, everyone. This is Ella. I'm calling from a health center in Central Alameda County in California. And I don't know if this is something you can answer today or if maybe something to consider for a future call. We are in the process of exploring using agentic AI for patient-facing outreach and education, potentially scheduling. And it's a little bit different than ambient scribe, for example, where we have already created a workflow for our provider to get consent from the patient, since California is a two-party consent state. And in California in particular, the idea of how to know when we need to get consent for using agentic AI feels sort of confusing. In California, they passed a law recently around requiring consent that, like agentic AI basically needs to identify itself at the front of the conversation and then like at certain points throughout if it's being used for certain activities, and then there are exclusions for that. And it's all feels like confusing to interpret what exclusions, what is the meaning of those exclusions. So when I've looked up, patient consent, informed consent, and even tried to review like what Kaiser sends me because I'm a Kaiser member in my own insurance, like I'm having trouble finding precedent there, and especially because it's going to vary state to state. And so it makes it hard to go find like a definitive legal interpretation on that. And some of the like digital technology advisory groups are publishing like one pagers with like, here's the status of informed consent state by state. This is two party, this is one party. And it's like, I can't make a workflow off of that. That's not helpful enough. So if that's something that you all could talk about in a high level, or if that's something for a future webinar, informed consent would be really helpful.
Yeah, maybe I can start and then welcome Randy, sort of, you're jumping in. So hi, Ella. So you're referring to the sort of, I think it was the California AI Transparency Act, which sort of passed last session. So since we have a national audience, like every state is different. Every state has its own requirements around consent and disclosure. Most states don't have like an AI specific consent or disclosure requirement. California is one of the, handful of states that does and is probably like at the forefront of regulating this space, given the recent bill. I think it's something we can provide like more of a national overview on in a future webinar if that's helpful. I think for your specific case, Ella, like given you're talking about this workflow versus that workflow and like a very specific California law, like happy to chat offline about we're doing that work all the time in terms of advising on like really specific use cases, like how to handle this consent and disclosure. And so I'm happy to connect sort of afterwards and see if we can be helpful specific for what you're evaluating.
Very cool, thanks.
Randy, I don't know if there's anything you want to add there.
I mean, I'll just add that it's sort of like consent and disclosure has an interplay among like existing state laws, like you mentioned, Ella. So there's like the wiretap statute, if there is a recording element, a voice, or sometimes it's visual. And then there may be privacy considerations that exist, like irrespective of AI use, and then layer on top of that any AI specific consent requirements, where states might be regulating down to a specific use case, which may not be relevant, or may apply like broadly to just anytime someone is interacting with AI, that they're aware that they're interacting with AI. So it is sort of multifaceted, and we could have a whole sort of separate conversation about benefits of consent and disclosures around AI and like what should be in them.
Yeah, I think a lot of the technology that's offering AI agent doesn't, a lot of customers and vendors as well choose not to disclose that the patient would be speaking with an AI agent. They'll like answer it if asked, but they're just like, I'm an agent from such and such, or they call them virtual assistant from such and such.
So I would say that,
yeah,
I mean, I would say just like, I don't have the percentage in front of me, but there is like definitely not a majority, but some of the longstanding AI laws that existed before AI became a thing. And some of the sort of earlier past ones generally require some types of disclaimers that you are interacting with an AI tool in a way that the consumer would know they're interacting with an AI tool. Now, whether virtual is sufficient to meet that threshold is probably something that lawyers could debate. But yes, and I think if somebody were to ask me how to deploy a technology across 50 states, and we get asked those questions, in general, I am advising that there is some sort of, not necessarily consent, but disclaimer to the end user that they're communicating with an AI tool. If they don't want to wait and go state by wait for each state to sort of like domino in terms of like passing that type of legislation. But happy to talk with you and Jared offline if helpful.
Thanks, Ella. And I see we have one more hand raised. It's probably the last question we have time for, but happy to take others offline. Ellen, if you want to unmute and ask.
Yeah, hi, I'm Ellen Rodarte. I'm a physician in California, and I'm working with several FQHCs here. And we're kind of taking a different approach. We're doing workflows and patient engagement, but we're using AI to help the clinics build their own deterministic tools so that there's never an AI interacting with the patient. The AI actually interacts with the clinicians and the teams to create deterministic workflows with embedded videos. The AI helps them make a video. So I just wonder, is that something we've done that because we feel that that way the patient is never really interacting with an AI, they're interacting with something that the clinician built with an AI. And is that regulatory wise safer? Thank you.
I don't think that the regulations are not that nuanced that it really distinguishes between the two. I think where the regulations draw a distinction is when the user, consumer, patient member is interfacing directly with the AI tool versus it being used to augment support delivery via tool relied upon by healthcare providers. But in terms of there's no distinction based on who sort of developed the tool that's being deployed.
Jared or Maya, anything to add?
No.
Okay. Well, thank you all so much for joining us today. As I mentioned earlier, we always really look forward to the session, and I think it's one that people find really insightful. So appreciate you all being here and taking the time to join us today.